Okay.
You're showing it off a phone or something because your picture's really small.
I'm showing it off my laptop.
All right, I think we're fine. Go ahead. Seems to be
Fine
okay.
now?
Yeah. Go ahead.
Good afternoon. So we'll be doing HIV in pediatrics. So it's myself, Dr. Butu, Dr. Maduna, and Dr. Mdebule. So this is what we're gonna discuss. So human immunodeficiency virus, it's a viral infection which attacks the body's immune system at cellular level, and if not treated, progresses to AIDS and death. So we have two main types of HIV. So HIV-1, which is the most common, and HIV-2, which is relatively uncommon. It's mostly found in West Africa. So worldwide, the predominant strain, the predominant type is HIV-1, accounting for around 95% of all infections. So HIV has transformed from a universally fatal disease to a chronic manageable illness, which is preventable and treatable. So HIV comes from the lentivirus family, which is a subgroup of the retroviruses. It's an enveloped RNA that replicates via a DNA intermediate. So members of the retrovirus family generally cause immunodeficiency, malignancy, or CNS degeneration. So HIV infects helper T and CD4 subset of lymphocytes, macrophages, and other cells. So the glycoprotein GP120 has a great affinity for the CD4 molecule on the cell surface. So the gut is the most common portal for vertically transmitted postnatal infections, but it does not have CD4 receptors. So HIV enters via the co-receptors.
Sorry about that. Okay, I'm struggling just to escape this. Sorry, Prof.
So the co-receptors being the CCR5 and the CXCR4. So viral replication in lymphoid tissue and release of inflammatory mediators leads to physiological alteration and immune dysregulation before the disorder is clinically evident. So HIV irreversibly infects cells, so they either die or are destroyed. So when a large proportion of these lymphocytes have been destroyed, it leads to the immune collapse and resulting in clinical manifestation of AIDS. So the disease progression, so it goes from asymptomatic, symptomatic, AIDS, and death. So this occurs more rapidly in children because after 1 month of infection, viremia will, so there will be high viremia, but it doesn't go down unless there is art intervention at that point. So my colleague will take over.
Good day, everyone. I'm Kanye Samtebule, and I will continue with a presentation from clinical suspicion of HIV in children. So a child may present with recurrent infections, unusual microorganisms, unusual presentation and cause of common infections, unexplained failure to thrive or wasting, resistant oral thrush, unexplained hepatosplenomegaly and generalized lymphadenopathy, unexplained tone disturbances. So coming to the clinical manifestations of HIV in children, on the central nervous system, a child may present with progressive encephalopathy, where a child may have impairment in memory and cognition and eventually dementia. On the head, eye, ear, nose, and throat, they can present with retinitis, anemia, frequent nosebleeds, severe oral thrush, enlarged parotids, otorrhea, otitis media, and sinusitis. And then on the cardiovascular system, they can present with cardiomyopathy and then eventually congestive cardiac failure. And then on the GIT, they can present with HIV enteropathy, where a child may have malabsorption, as well as virus infection, as well as infection with virus microorganisms, which can lead to chronic diarrhea, and then the child can have failure to thrive. On the renal system, they can present with nephrotic syndrome secondary to HIV nephropathy. Dermatologically, they can present with seborrheic dermatitis, angular cheilitis, fungal infections of the skin as well as of the nails, herpes zoster infection. They can also present with clubbing. Hematologically, they can present with easy bruising secondary to thrombocytopenia. Coming to diagnosis of HIV in children, for children less than 18 months of age, HIV PCR is used as a screening as well as a diagnostic tool. And then for children of 18 months to 24 months, HIV ELISA is used as a screening tool and HIV PCR for confirmation. So for children of more than 24 months of age, HIV ELISA is used as both a screening and a diagnostic tool. World Health Organization staging, we have 4 stages. Stage 1 is asymptomatic, or the child can present with persistent generalized lymphadenopathy. And then stage 2, mild disease. They can have papillopruritic eruptions, seborrheic dermatitis, fungal nail infections, angular cheilitis, lineal gingival erythema, extensive human papillomavirus or molluscum infection that can occupy greater than 55% of the body area or the face. They can also present with recurrent oral ulcerations of greater than 2 episodes in 6 months, parotid enlargement, herpes zoster of greater than 2 episodes in 6 months, recurrent or chronic upper respiratory tract infections, such as otitis media, otorrhea, sinusitis of greater than 2 episodes in 6 months, as well as hepatosplenomegaly. And then stage 3 is where there's advanced disease. They can have unexplained mild to moderate malnutrition that constitutes 60 to 80% of expected body weight, unexplained persistent diarrhea of greater than 1 month, unexplained persistent fever. It can be intermittent or constant, that is greater than 1 month, oral candidiasis outside the neonatal period, oral hairy leukoplakia, pulmonary tuberculosis, severe recurrent presumed bacterial pneumonia, that could be greater than 2 episodes in 12 months, acute necrotizing ulcerative gingivitis or periodontitis, lymphoid interstitial pneumonitis, unexplained with a duration of greater than 1 month. Could also present with anemia of less than 8 grams per deciliter, neutropenia of less than 1,000 per millimeter cubed, or thrombocytopenia of less than 30,000 per millimeter cubed. As well as HIV-related cardiomyopathy or HIV-related nephropathy. Coming to stage 4, they can present with unexplained severe wasting or severe malnutrition not responding to nutritional rehabilitation, pneumocystitis, pneumonia, recurrent severe bacterial infections greater than 2 episodes in 12 months, chronic herpes simplex virus lasting for greater than 1 month, disseminated TB or other mycobacterial disease, Kaposi sarcoma, esophageal candidiasis, central nervous system toxoplasmosis, cryptococcal meningitis, rectovaginal fistula, chronic lung disease with bronchiectasis. Any disseminated endemic mycosis, cryptosporidiosis with diarrhea of greater than 1 month, cytomegalovirus infection of organ other than the liver, spleen, and lymph nodes, and onset occurs at age of greater than 1 month. Candida or papillomavirus of the trachea, bronchi, or lungs, cerebral or B-cell non-Hodgkin's lymphoma, progressive multifocal leukoencephalopathy, HIV encephalopathy. I'll be handing over to my colleague to continue with the presentation.
So the investigations that we do before we initiate antiretroviral therapy. We'd have our bedside investigations, which would be anthropometry. Head circumference would be important in children less than 2 years of age, just to also see how they're growing and to determine their growth and if they're growing well. It would be important to screen for TB and TB meningitis. And then if there are suspicions or if there's clinical indications for us to investigate, then we'll do so accordingly. Also screening for cryptococcal meningitis. So our lab investigations for a patient that has just tested positive, we'd like to do a full blood count at the first, second, and third visit, then annually, if on AZT, a urea and electrolytes and a estimated GFR, lipid profile if on protease inhibitor, then test annually, a liver function test, a CD4 count and percentage of it, and then we do that as an annual test as well thereafter. Viral load at month 6, a year into antiretroviral therapy, and then every year after that. So I think this is very similar to in adults. So when we defer or fast track antiretroviral therapy, well, fast tracking would be the same, but deferring it would be if there's a confirmed TB diagnosis, we'd defer, if not yet on heart, for 2 to 4 weeks. If the patient also has TBM, we'll start antiretroviral therapy at 4 weeks, irrespective of the CD4 count, just to avoid iris. Cryptococcal meningitis, we defer for 2 weeks if the antigens are detected, but if there's no clinical features, and for 4 to 6 weeks. And then we'll fast track it. We'll start antiretroviral. For fast tracking, we'll have to start it 7 days after addressing social issues, counseling, and adherence to the caregiver. So that would be as soon as possible, as soon as we actually diagnose the HIV. And then it's important to start in children less than a year, within 7 days, a CD4 count of less than 200 cells, WHO stage 4, and to fast track in MDR TB and XDR TB unless TB meningitis is diagnosed. That's when we'll defer. So these are the regimens that are being used currently in pediatrics. So for neonates, we'd use AZT, 3TC, and NVP. And that's with children from birth to less than 4 weeks of age, between the weights of 2.5 kilograms and 3. And then greater than that, so now infants and children will use ABC, 3TC, and lopinavir, ritonavir. And in children, we'll use abacavir, 3TC, and dolutegravir. And then from more than 10 years of age, we'll start then transitioning the patients to adult and adolescent regimens. So these are just the dosages that we would give out for the relevant age groups and weights. So second and third line ART regimens for children and adolescents with confirmed virological failure. So if we're going to use an NNRTI-based regimen, resistance test is not required. So the regimen would be abacavir, AZT, TDF, or TDF, and then you add it with 3TC or FTC, and then you add efavirenz or nevirapine. So resistance test is not required. The weights are there. And yeah, the regimen that is required is also weight dependent. So with the PI-based regimen, for more than 2 years, the regimen is abacavir or AZT or TDF, and then you either add 3TC or FTC, and then you also either add lopinavir, ritonavir, or ATV/ritonavir. A resistance test is required for both the PI-based regimen and the INSTI-based regimen. And then if there's PI resistance, you'd have to refer the patient to a third line committee, and then the IN STI regimen resistance, then you'd refer also to a third line committee. So there was indications for starting and stopping Bacterium. So it's age and HIV status. If an HIV positive infant of less than a year of age, you start Bacterium irrespective of the CD4 count. An HIV positive child between the ages of 1 and 5, you start if the CD4 count is less than 25%, and if they're in WHO stage 2 to 4. You stop it if the CD4 count is greater than 25%. So if it's an HIV positive child less than 5 years with PJP infection, you start Bacterium after the treatment is completed, and then you continue until the age of 5, provided that the CD4 count is more than 200 cells. And then in HIV positive children more than 5 years and adults, you start Bacterium prophylaxis at a CD4 count of less than 200 cells or WHO stage of 2 to 4. Sorry about the typo. And then you stop it if the CD4 count is more than 200 cells, regardless of the staging. So given that we're doing family medicine and we are in primary healthcare facilities, I thought that it was very important. Well, we thought that it was very important for us to add what the impact of primary healthcare has in HIV in pediatrics. So the impact that it has, I don't think we realize that HIV in pediatrics, the point of diagnosis would be at our clinics, at the POPDs that we're running, because that's where we'd start with the index of suspicion. That's where the parents would come in and get their ELISAs, and the children would get their ELISAs or PCRs, depending on age. And then that's when we'll start our primary management and initiate that. And primary healthcare, alongside with the NGOs that they are currently working with, they help a lot within the disclosure of the disease, and tools such as Kids Alive, which is an initiative that was started by, I think, Zoe Life. They have different forms of tools to help children understand their diagnosis and how to deal with it. Youth clinics as well. It's better, I think it's always better for people of the same age dealing with similar issues to sit and try and talk about it so that they can get a better understanding from their age mates, rather than just an adult telling a child that you're HIV positive and that being that, without offering counseling in the form of a psychologist. But the age gap would still be there, thus making it very difficult for the child to understand. So initiatives like the youth clinics that most of our clinics have, and also our adherence clubs, which also make it very interesting for them to actually understand what comes about of their diagnosis and the importance of adherence thereof. And that is all. Thank you so much.
Thank you very much. Any questions or comments from anybody in the meeting? Dr. Chabeya, anything to add?
No question particularly for me, but this was a very good presentation, actually. It was very good. Yeah.
Dr. Alagidedi, anything you want to add?
No, Prof. I'm good. Thanks.
All right, good. Yeah, I think most of the challenge in primary care, besides the issues you talk about being much more focused on continuous treatment, is the challenge of doctors feeling that they are unable to manage this. And yes, you don't expect always to remember every detail, but it's not as intimidating as lots of doctors tend to make it out to be. So I think you'll find that challenge, and I think most of you as interns are not as afraid or as intimidated, and do keep that up. One just needs to refer to the text to get the doses and exactly what to do Right. So don't get intimidated in managing pediatric patients. And I think the key thing is to understand that challenge of a child being able to be managed well, because kids can be very difficult to manage for their parents, especially as they grow up, to be taking tablets every day, and the parent needs to be a part of that equation to understand what they think about the disease, how much information they give to the child, and for you to negotiate those kinds of decisions about what sort of information the child gets. So those are important considerations in primary care. Compliance matters a lot in primary care. Good. Any other comments? If there are none, we can stop here. Okay, thank you all very much. Take care, and we will see you next week. Dr. Aki will be dealing with it. I'm on leave from